Good morning, student. I am Dr. Bhupendra Shah, Assistant Professor of Department of Internal Medicine, BP Koirala Institute of Health Sciences, Dharan, Nepal. Today, we'll discuss about lymphoreticular disease. This presentation is for 6th semester MBBS student. So, in this today's presentation, we'll discuss about the epidemiology, clinical feature, and management of chronic lymphocytic leukemia. And we'll also discuss about the epidemiology, clinical feature, and management of the Hodgkin lymphoma. Okay, basically we'll discuss about the CLL and the Hodgkin lymphoma. What is chronic lymphocytic leukemia? As the terminology say, leukemia means there is a problem in the blood and the bone marrow. The main problem is there is lymphocytes, lymphocytic proliferation. In chronic means it should occur at least for more than 3 months. So we have to know the basic difference between chronic lymphocytic leukemia and lymphoma. In lymphoma, there is accumulation of this lymphocyte in the particular tissues, whereas in leukemia there is the excessive amount of this lymphocyte in bone marrow and the blood. Okay, so to define the chronic lymphocytic leukemia, it is one of the monoclonal disorder which is characterized by accumulation of functionally incompetent lymphocytes. Okay, remember this is the monoclonal one. This is not the polyclonal. Lymphocytes are supposed to be polyclonal, which has to produce different type of the antibody, but this is monoclonal one, same type of cells. And there is functionally incompetent lymphocytes. These are the lymphocytes which are incompetent, which cannot produce the antibody later on. Okay. The epidemiology, it is the most common leukemia in adult. Okay. As you can see in the picture, this pink one is for the female and the blue one is for the male. The incidence of the CLL increases with the age and peak at around age of 65. Okay, is very uncommon condition in child, and it is male predominant condition. Okay, so to summarize, CLL is the disease of the elderly male. So what are the clinical features? Incidental. Sometimes, most of the time, the course of the disease is insidious. They are asymptomatic. Patient goes to the hospital for another reason or no currently, but when they check their blood, they see some abnormality. Later on, they diagnose as a case of CLL. So asymptomatic. And another mode of presentation is you can see the enlarged lymph nodes. Sometimes you can see the enlarged lymph nodes in the cervical area, in the axillary area, or in the inguinal area. You can see the enlarged lymph nodes. Okay. And as I've already told, this is the conditions where the lymphocytes are functionally incompetent. So the patient are more predisposed to have the infection. So patient can present with the infection like pneumonia, like UTI. Okay. And patient can have also the feature of the massive splenomegaly, like patient can have feature of early satiety, dragging sensation in the left upper quadrant, heaviness over there. Okay. As the bone marrow are infiltrated with the lymphocytes, there is little space for the RBC and the platelet. So patient can have anemia, and patient can have thrombocytopenia, and they can have a feature of the anemia and thrombocytopenia. Like the feature of anemia, they can have fatigability. Like a feature of thrombocyte, they can have petechiae. Okay, these are the symptoms of the CLL. In the physical examination, you have to examine the patient properly, and when you examine the eyes pallor, then you can see the pallor. Sometimes you can see the petechiae, and if you do the abdominal examination, sometimes you will get the splenomegaly, and sometimes you will get the hepatomegaly. That's why you need to check the different system properly. If you investigate the suspected patient of CLL, then hemoglobin low, as I have already told, may be normal or may be low. Leukocyte is very high, 50,000 to 2 lakh. It can go 2 lakh. It's very high. And in the leukocyte, the main leukocyte that is going to increase is lymphocyte. The lymphocyte is very, very high, and platelet count will be low in a patient with CLL. Okay. But to diagnose whether this patient has CLL or not, we need to do some tests, like we have to do the peripheral smear. Most of the time, we can diagnose the CLL by doing the peripheral smear. In the peripheral smear, you can see these are the lymphocytes. These are lymphocytes. This is one of the the hallmark of the CLLs, where there are some large type of cell with irregular margin and same breakdown. These are called small cells. The finding of the small cell suggests the diagnosis of the CLL. This may be one of the MCQ question for you people. And we have to know what type of lymphocyte there is, there is. So if you do the flow cytometry, then you can see the B lymphocyte with CD23. This is CD23, CD10. These are the, sorry, CD23 and CD20. These are the CD cluster of differentiation, which is predominant in the cells of the CLL patient. Okay. We can do flow cytometry as well as the peripheral smear. So after doing all these tests, then we have to stage the patient. This staging is given by Binet, and it has clinical stage A, B, and C. A is there is no anemia, no thrombocytopenia, and there is lymph node enlargement, but the areas of lymph node is less than 3. Okay. In stage B, there is no anemia, no thrombocytopenia, lymph node enlargement is more than 3. In stage C, there is anemia or thrombocytopenia, and there can be also lymph node involvement. So if there is anemia and if there is thrombocytopenia, it's already in stage C. Okay. Then what? As I have already told you, it has indolent course, it has asymptomatic phase. So there is certain indications for the treatment. We need not to treat all the patients with CLL. But if someone has the weight loss for more than 10% over 6 months, if someone has extreme fatigue and feature of progressive marrow failure like anemia and thrombocytopenia, progressive splenomegaly, and fever more than 2 weeks, that is attributed to the CLL. In such scenario, we have to treat the patient with chemotherapy. Okay. So as a third year MBBS student, just don't go to the details of the treatment, but just know what are the treatment available. In the chemotherapy, the classical treatment that is available is chlorambucil. The newer one is fludarabine, cladirabine, and pentostatin. These are the chemotherapy that can be used in a patient with CLL. Just know the name. Okay. And sometimes if the disease is localized, if there is only lymph node enlargement, then you can do the radiotherapy. And one of the treatment modality is the allogenic stem cell transplantation. These are the treatment modalities. But we should never forget about treating the infection. We should never forget to immunize the patient at least against the Streptococcus pneumoniae and influenza virus, because we have to immunize them with the vaccine so that we can prevent the infection, because infection is one of the main cause of mortality of patients with CLL. If there is infection, then we have to treat them with the broad spectrum antibiotics. Okay. I think you have understood something about CLL. So CLL is one of the most common leukemia in the adult. It is, you will get this condition especially in elderly male, and sometimes it has the indolent course, and they can present with lymphadenopathy, feature of immune dysfunction, splenomegaly, feature of anemia. In the test, the main cells that is going to increase is leukocyte, and that too the lymphocyte is predominantly increased. And if you do the peripheral smears, then you will see the small cells. And if you do the flow cytometry, then you will see the CD23 and CD20 type of B lymphocytes cells. In the treatment, is the chemotherapies. We can use chlorambucil and fludarabine and cladirabine. We can use. Okay. Now let us go to the next topic, that is lymphoma. So as I have already told, in the lymphoma, it is also there is also the unchecked proliferation of the lymphocytes. Sometimes the B lymphocytes, sometimes the T lymphocytes, but that occurs predominantly in the certain tissues. So it's basically divided into Hodgkin and non-Hodgkin lymphoma based on the clinical presentation and the histology. So in Hodgkin lymphoma, it has a bimodal peak. So like it has peak of around 20s, and it can also like the prevalence increases by 50s. And etiology, there are so many etiology that has been like proposed, but mostly we do not know what is the exact etiology of the lymphoma. So what is the pathological hallmark that you need to know? The pathological hallmark is Reed-Steinbach cell, that you can see the two cells and like two nucleus cells over here, and which are like surrounded by the normal cells here. This is RS cells. The presence of this Reed-Steinbach cell suggests us to make a diagnosis of the Hodgkin lymphoma. Okay. So pathological classification given by the World Health Organization is it is lymphocyte predominant one, nodular sclerosing type, mixed cellularity type, and lymphocyte depleted. These are the types of classical Hodgkin lymphoma. Okay. In the clinical feature, most of the time we suspect patient to have Hodgkin lymphoma if they present with the large lymph node. These are usually painless, and if you palpate them, it is usually rubbery one. And this the spread is contagious. Okay, there is groups of lymph node over here. Then we have to think about the Hodgkin lymphoma as one of the possibility. Yes. So how can we confirm? We have to do the lymph node biopsy. Sometimes we do the FNEC, but most of the time we require the lymph node biopsy. And after doing the biopsy, we have to see the histology, and we have to identify the lymphocytes. You have to identify the Reed-Steinbach cell to confirm the diagnosis of the Hodgkin lymphoma. And based on the histology finding, you can even categorize the different types of the Hodgkin lymphoma. So other supportive investigation we can do is we can do the full blood count, where we can see hemoglobin may be the low. ESR will be very high in a patient with lymphoma. Lactate dehydrogenase, which is a marker of this cell turnovers, it can be elevated. And sometimes you have to do the chest X-ray because like there can be enlargement of the mediastinal lymph nodes, and we have to see whether there is enlarged mediastinal lymph node or not. And sometimes we have to do the CT scan of the chest and the abdomen to see whether there is a enlargement of the lymph node or not. It helps us to stage the patient with Hodgkin lymphoma. So but, we have to differentiate between the Hodgkin and the non-Hodgkin lymphoma. In the neoplastic cell, as I've already told, we'll see the Reed-Steinbach cell in Hodgkin lymphoma, B cell in non-Hodgkin lymphoma mostly. Incidence, it is like a predominant leap you see in the adult population, but incidence is but non-Hodgkin is more common than the Hodgkin lymphoma. Then location is a unicentric. There is only like involvement in only one site, but in case of non-Hodgkin, there can be involvement in the multiple sites. Spread is a predictable, like the contagious spread that is predictable. In case of non-Hodgkin, it's a non-contagious spread. External nodal diseases are more commonly involved in non-Hodgkin lymphoma, like skin. There can be involvement of skin. There can be involvement of the testes. There can be involvement of the intestine, gastric epitheliums. It can involve in non-Hodgkin lymphoma. And systemic symptoms are more common in Hodgkin lymphoma. But it can also occur in non-Hodgkin lymphoma because most of the time we get a patient with the non-Hodgkin lymphoma with fever and weightless. So then we have to stage the patient with Hodgkin lymphoma, that is post-old modification of Ann Arbor staging. Previously it was Ann Arbor staging, but Cotswold have modified this staging system. So stage 1 is only single lymph node involved. There is only one lymph node involved. Stage 2 is that multiple lymph node, but is above the diaphragm or under the diaphragm. Only one site. Stage 3 is there is multiple lymph node on both sides. One lymph node here, another lymph node just below the diaphragm in the abdomen. This is stage 3. And stage 4 is multiple extranodal site like intestine, like lungs. Then you can say it's the stage 4. So stage 1 is a single lymph node. Stage 2 is the multiple but same side of the diaphragm. Stage 3 is the both side up and down. Stage 4 is the extranodal lymph nodes. X and E is like given by the Cotswold. X is if there is like large lymph node of more than 10 centimeters, then it's called X. If there is extranodal extension, that is E. And we have to also know about the B symptoms in Hodgkin lymphoma, because the presence of B symptoms signifies the poor prognosis. Like if someone has weight loss of more than 10%, if there is a fever, if there is drenching nitrate, then it's the B symptoms. The treatment, as a third year MBBS student, you need not to know the details of the treatment, but you have to know if someone has the like stage 1A up to stage 2A, then we have to treat with the ABBD regimen or standard Stanford V regimen. That is 6 cycles and 2 cycles respectively, plus the involved site radiation therapy you have to give. In stage 2B to stage 4, we have to give the ABDB regimen and standard 5 regimen, but there is difference in cycles. What is ABBD regimen? A means adriamycin, B means bleomycin, B means vinblastine, and D means dacarbazine. Standard V regimen is I have kept in alphabetically: adriamycin, bleomycin, etoposide, macrolithimine, prednisolone, vinblastine, and vincristine. They are the standard Stanford V regimen. Just you know the name of the chemotherapies. Okay. Thank you for your kind attention. So Hodgkin lymphoma is a condition, so like where you can see the red stem box cells. The common promoter presentation is the lymph node enlargement, it's a painless, it's robbery. It has different subtypes, and we have to differentiate from the non-Hodgkin lymphoma and treatment according to the staging. Thank you for your kind attention. If you have any problems, any comments, any queries, then you can write in the comment section. I will be happy to answer your comments and answers questions. Okay. Thank you.